My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Hello and welcome to COAG Conversations. Our guest is Professor Emmanuel Favaloro, and Professor Favaloro is a principal hospital scientist at the Institute of Clinical Pathology and Medical Research, Westmead Hospital, and he's a founding member of the Sydney Centers for Thrombosis and Hemostasis. He's affiliated with both Sydney and Charles Sturt Universities and is current editor-in-chief of Seminars in Thrombosis and Hemostasis. The title of Professor Favaloro's series is The Many Faces of Von Willebrand Factor, or Von Willebrand Factor ADAMTS13 Malignancy and Beyond. For conversation number 3, we are going beyond because it's entitled Von Willebrand Factor and ADAMTS13 Thrombotic Mechanisms and Cardiovascular Diseases. So, Dr. Favaloro, in our previous session, we examined von Willebrand factor's role in inflammation and its multifaceted relationship to malignancy. In today's session, we'll examine von Willebrand factor as it is involved in arterial disease. Is it safe to assume that von Willebrand factor has a prothrombotic relationship with arterial disease?
So again, George, thank you to yourself and to Biomedica Diagnostica for inviting me to speak at these COA conversations. So we previously spoke about the concepts of the lack of von Willebrand factor or the most functional or high molecular weight forms leading to bleeding risk, such as can occur in congenital von Willebrand disease or acquired von Willebrand syndrome, or how excess levels of von Willebrand factor, or again, the most functional or high molecular weight forms, can lead to increased thrombotic risk, for example, in malignancy or in COVID-19. We also spoke briefly about the VWF to ADAMTS13 axis, where a relative overstimulation of endothelial cells can lead to excess von Willebrand factor and exhaustion or consumption of ADAMTS13, with the most severe representation evident in TTP. However, high VWF to ADAMTS13 ratios can also be seen in some cancers, and here also a risk factor for thrombosis.
Can we take a second look at the von Willebrand factor and particularly the relationship to endothelial cell function and apply that to arterial thrombosis?
Sure, George. And for this, I have another slide that I'll like to put up, and which basically encapsulates the thrust of the conversation. So this slide, to some extent, mirrors the previous slide that I showed in relation to malignancies or cancers. But what we're talking about here now is cardiovascular disease or cardiovascular dysfunction. So this is kind of similar to some extent to what happens in cancer. You can get an increase in von Willebrand factor due to endothelial activation, but also you can get a loss of von Willebrand factor or a loss of high molecular weight VWF in certain conditions, leading to increased bleeding risk. So endothelial dysfunction can occur through various mechanisms in cardiac disease, but essentially if you get an increase in von Willebrand factor due to an activation of endothelium, you can get the same sort of events that I mentioned before in terms of angiogenesis. You can get also an increase in von Willebrand factor to ADAMTS13 representing a thrombotic risk. But in some conditions, for example, in left ventricular assist devices or in aortic stenosis or even in some congenital disorders of the heart, you can get an acquired von Willebrand syndrome. And then in this case, you have a loss of VWF or you have a reduced VWF to Adams tier 13 ratio.
Since cardiac disease prevalence rises with age, can we illustrate an age-related component to ADAMTS13 activity and von Willebrand factor? And I'm asking for a friend.
As I indicated, we should start looking at both VWF and Adams tier 13 in combination rather than looking at one or the other on its own, because they're partners, if you like, in terms of what happens in disease. And both VWF levels and Adams tier 13 activity have been correlated in older patients with atrial fibrillation and an increased stroke risk. Plasma VWF levels are increased, whereas Adams tier 13 activity levels are reduced in coronary artery disease, ischemic stroke, and in venous thromboembolism. And you'll know from previous experience also that VWF increases with age in general.
Now, has our understanding of ADAMTS13 and VWF levels led to any particular therapies?
Indeed, George, and I'm just going to put on another slide. In this slide, I'm just showing some of the potential targets that may combat excessive von Willebrand factor activity. Now, let me caveat this conversation from the start to say that I'm not a clinician, I'm a scientist, and this is just in relation to material that I understand to be in progress in a research capacity. So this is not something that's happening at the moment. But there are some potential targets. So there are a number of targets against von Willebrand factor itself. So caplazuzumab is an antibody fragment that's been genetically engineered to bind with VWF, and it blocks the interaction of VWF with platelets. Remember, I talked about von Willebrand factor binding to glycoprotein 1b, and it prevents thrombus formation, and it's widely used as an adjunct therapy for TTP. So it's actually used in TTP to prevent thrombosis. Potentially then one could consider that this might be a drug that may be able to be used to prevent thrombosis in particular situations, for example, in severe COVID-19 or potentially in severe cardiac disease associated with thrombosis. But again, this is just a theory. It's not something that's practically in use today. And there are a number of other VWF aptamers. These are artificial oligonucleotides that bind to one or other or more specific target molecules, and they exhibit a range of specificities or affinities with little or no off-target binding, and sometimes classified as chemical antibodies, and they're under evaluation. So there are a number of VWF aptamers that could also be used, which will bind to VWF and then prevent that VWF from binding and causing thrombosis. Another potential therapy is, of course, recombinant Adams tier 13 in the case of Adams tier 13 deficiency, where that is leading to a state of excess von Willebrand factor. The other side of the coin is to target glycoprotein 1b, and there is at least one potential therapy for that, amphibatide, which is a novel snake venom-derived glycoprotein 1b agonist, and it's also being assessed for its potential utility in TTP. It inhibits VWF and thrombin binding to glycoprotein 1b. And again, one can envisage that such an agent could potentially be useful in conditions where you have an elevated level of von Willebrand factor as a risk for thrombosis, in particular in conditions such as severe COVID-19, for example, but potentially also in cardiac diseases where there is a huge amount of von Willebrand factor, potentially as a risk for thrombosis.
You know, it's interesting to see that platelets may be part of the pathology in both in cancer and in cardiac disease related to the von Willebrand factor and ADAMTS13. Well, I'll ask you to speculate, when can we expect these new therapies to arise?
Well, George, another great question. So some of the therapies in terms of COVID-19 will probably be entering clinical trials at some stage, I would imagine. Certainly, they've been proposed by a number of groups that we should start to look at those potential therapies in severe COVID-19 to prevent thrombosis in some of those patients. In terms of cardiovascular disease, I think it's way too early to consider such therapies, and there's probably other therapies that we can utilize for cardiovascular disease at the moment. In assessing the effectiveness of all treatments, there needs to be an assessment also not only of the benefits or of the efficiency of those treatments, but also the assessments of risks. And there needs to be a balance between the risk of thrombosis and the risk of bleeding. And that's a difficult balance to achieve when the balance is disrupted by disease, George. So to some extent, I'm glad I'm not a clinician that has to actually manage this sort of event in people such as ourselves, George. So I'm glad that I'm actually not tasked to do this. I'm just glad that I'm just talking about the theoretical aspects and perhaps what we can look forward to in the future.
Exactly. And as a lab scientist, I look forward to being able to monitor some of these therapies. Well, that concludes our third and final conversation. Again, Dr. Favaloro, thank you for your expertise. We do encourage participant questions and comments, and we have a link on the Biomedica Diagnostics website for you to forward your questions or comments that we will answer. Thanks also to Biomedica Diagnostics for sponsoring COAG Conversations, and thank you for participating, and continue to watch for further COAG Conversations on the website in the future. Thank you very much.
Thank you, George. Again, thanks to yourself and to Biomedica Diagnostics for permitting me to partake in these conversations. And if I can just end by having a plug for seminars on thrombosis and hemostasis, we are celebrating our 50th anniversary over the next year or so, and we would encourage readers to connect with us on our pages on the internet. Thank you very much again.
Thank you.